So I'm Dario Gattuso. First of all, welcome back again. Welcome again. My name is Dario Gattuso. I'm the clinical program manager of Concept Medical, and I'm putting ahead some works with Professor Sangiorgi in ED field that maybe he will introduce during his talk too. Today we have with us Professor Sangiorgi, that is a doctor that is specialized on cardiovascular disease, and is professor in the University of Tor Vergata in Rome. He is expert of many fields, also physiopathology and anatomopathology. He is an interventional cardiologist and has started his career in United States in Mayo Clinic. Please, Max, feel free then to add all the things you want.
Yeah, and you're doing so many things that it's enough. It's enough.
Yes, and he has published more than 300 works in many international journals, and has been awarded in 1998 as the best researcher in American Heart Association. Now after this he has received some other awards regarding his research work, and I think that you can confirm, Max, that this new cutting-edge approach to the erectile dysfunction is given to be a new research approach that has created good results into the first phase we are analyzing.
Yeah.
Okay, so I don't know if
how many people are connected. Are you aware of the number of people? I mean, there are colleagues, doctors, radiologists, cardiologists, urologists. Who will be with us today?
Till now, we have 110 connected people, and they are of different fields, from interventional cardiologist to urologist to andrologist. We already published on the chat box the questionnaire regarding the assessment that we will do before the training and after the training. And it's something that, as you know, will give also a general panorama of the things. Now, before starting, our colleague is going to project a small video introduction of 1 minute, and then we will move on with the topics. Okay? Thank you, Max. Thank you so much for this introduction. So now it's the high time to start with the projection. I make you presenter, and then you can start the presentation. Okay.
Okay. Okay.
While we are going to do the webinar, if there are any questions, we will use the time after each topic to put ahead the question. Okay, we will help you in doing this.
Okay.
Okay, enjoy the webinar.
Thanks, first of all, and welcome everybody. It's a big pleasure for me to be here. As Dario said, I'm an interventional cardiologist who has mainly work not only in coronary but also in peripheral intervention. And this is the reason why a few years ago, it's almost 5 years from now, that I started this pioneeristic approach in the mechanical revascularization of erectile dysfunction. Now, first of all, in the following slides, you will see probably some information that for urologist colleagues are normal, a little bit less for cardiologists, and probably radiologists are not aware of the connection that ED represent in terms of systemic atherosclerotic disease in many patients that, as a cardiologist, we see in our cath lab. Of course, when you start to talk about erectile dysfunction, the usual mood is to have fun and have joke, but you will see that this is a very serious problem for our male patients due to the fact that you can imagine it's really a big deal in terms especially of quality of life, especially in terms of self-esteem, especially in terms of depression, and of course, last but not least, in the relationship with the partner. So I think that when we approach this type of patient, first of all, we have to think about a very serious disease, and we have to approach the patient in a very open mind way, try to offer a solution, and trying to understand if the problem it's an organic problem, or if it's a psychological problem, or as we say, to summarize the problem, if the problematic part is between the ears, or is between the legs, or is in between the couple. Because you will see, there are many confounding situations. First of all, what I would like you to bring at home as a first message is that there are some myths surrounding erectile dysfunction. Usually patients, when they approach doctors regarding this problem, they are not, first of all, very confident in discussing about this issue due to the fact that there are some sexual taboos. And, it represents for us as a man, the power. And so I lost my power. I don't want to share with anybody that I have these difficulties. But the second problem is that many patients believe that nothing can be done. Many patients believe, especially in an older age, that, you know, it's something physiological. You know, the sexual power, it's normal that at 65, 70 years old, it's less than when I was 25 or 30 years old. And also many patients believe, probably due to the fact that they have done some tests and nothing is positive in the test that they have done, normal hormonal sexual profile. They have, you know, a normal prostate. That probably, you know, it's all in my mind. I don't have nothing, but I lose interest with my wife. I'm, you know, scary about the economic situation. So it's a bad moment, but probably organically speaking, I am completely normal. And you have to know that, of course, ED is a normal part of aging, but it's not related to age. So normally speaking, you will, you know, meet many patients that have 80 years old and they have a normal sexual relationship. So it's not a normal part of aging. The second thing that you have to realize that beside the quality of life that this type of disease impact on, it's a very important warning sign of cardiovascular disease. We will go deeper into this notion, but this is the message that you should keep in mind as a cardiologist. So it could be the first symptoms of underneath cardiovascular disease. Having said that, of course, this is normal for urologists, but you know, for cardiologists, perhaps they never thought about how we define erectile dysfunction. And these, of course, are urologists, andrologists, sexologists definition, but basically it's the recurrent inability to achieve or maintain an erection which is satisfactory for normal sexual intercourse. And if we start to look at numbers, you will see the last paragraph of this slide is that more than 300 million men worldwide have a sort of erectile dysfunction. For instance, in the United States, men between 40 and 70 years of age are affected 50% of some degree of erectile dysfunction. If we move into patient affected by chronic coronary artery disease, this percentage goes up, and we are reach 61% of patients have erectile dysfunction, of course, when appropriately investigated. This is the incidence in Italy, as you will see, of course, and it will when you will start to you know, look in your outpatient setting, you will see that it's very common that the first problem will turn on being the decade between 50 and 60, and then of course it goes up to 50% in the decade between 70 and 80 years old. Now, if you remember the anatomy, you know that the irroration of the male genital organ is mainly due by a branch of the interiliac artery, which is called hypogastric artery. Now you will see that probably this is the most difficult part in all the story for treatment due to the fact that there is a quite high variables for the anatomy. Let's say that 80% of the patient will show what is called an anterior division, which is depicted here in the slide. So you will have the internic iliac artery, you will have a superior gluteal artery or an inferior gluteal artery, which is also called internal and external gluteal artery. And then you do have a pudendal artery, which originates separate from these two major branches. So when approaching the first time this type of patient with angiography, you should first of all identify the major branches, which are the internal or superior gluteal artery and the inferior gluteal artery, and then the pudendal artery. In AP projection, you will see in the following slides, however, you can identify very well the pudendal artery due to the fact that the artery runs anteriorly and then moves around the bladder. So you will have the bladder in an AP projection in the middle of the screen, and you will see an artery that goes around the bladder and then moves internally to reach the basis of the penile. And the artery that runs horizontally towards the penis is the dorsal penis artery, which is also affected by atherosclerotic disease. Not very common as the proximal part of the pudendal artery or the middle part of the pudendal artery. The other thing that you have to be aware of is that the cavernous body are basically a structure which are or need to be considered as a sponge. So they have arteries in the middle of the cavernous body that are called cavernous artery, and from them you have the helicine artery that fill the connective tissue and the sinusoids that are made of the cavernous body. When you do have a vasodilatation stimulus due, for example, sexual trigger or olfactory trigger or visual trigger, basically there is vasodilatation of the main artery, the sponge increases its volume, and when the sponge increases the volume, will squeeze the venous plexus that is between the cavernous body and a very rigid, stiff structure, which is called tunica albuginea, which is around the penis. And therefore, when you have an erection, and in order to have a natural erection, you need basically intact nerves. So if you think about a tire, somebody who starts the airflow, you need to have, so, and this is of course, it's our brain with the sexual stimulation, you need to have a good flow, so a good sort of working compressor tubing. You have to have an healthy cavernous tissue, so the tires needs to be a good tire, and of course the ability to block the venous output from the penis, so you don't have to have an air leak in the tire. So when all these components work properly, of course you will have a normal erection. In the majority of the cases, you will see that the urologist colleagues will talk about arterial insufficiency, and of course, we are referring to this part. There is no good blood flow, so the blood cannot reach and increase when there is a dilatation stimulus. They can, talk about venous problem. So there is a venous leakage. So the blood arrives into the corpora cavernosa, but cannot be maintained inside. And there are some mixed ED. So when all the arterial and the venous part are affected. Now, if we move into ED causes, you will see then that, the majority, 40%, recognize a vascular problem. And the major risk factors are exactly the same that we see as a cardiologist in patients affected by coronary artery disease. So, for instance, smoking, and of course, these encompass the lifestyle changes that the urologists usually recommend. So a patient who presents with ED and smokes, usually the first recommendation is to stop smoking. It's the same recommendation that we as a cardiologist ask to our patient to do. You also realize from these slides that 40% is vascular, 30% is diabetic. So more than 70% of these patients will have some problems that we as a cardiologist are used to deal with. The minority, you will see 50% is related to medication. And of course, again, as a cardiologist, you know the effect that we may have with the beta blockers, you know the effect that we may have with diuretics, you know also the effect that you may have with patients who are taking psychotropic drugs, especially antidepressant drugs. So another good part of the problem is related to medication. Then minority of the causes, around 11%, pelvic surgery. So many patients with cancer of the prostates who do not or are not submitted to nerve sparing techniques may show with erectile dysfunction, which is of course related to damage of the nerves. There are some primitive neurological and endocrinological problems. And so I'm referring to, for instance, hypogonadism or hypotestosterones. But it's really a minority of the causes. You should focus on the 70% of the patient who are either diabetic or have an organic problem. The other problem in this story is that the urologist, of course, the first thing that they will recommend, beside cardiology consulting, to prescribe the PDA5 inhibitors, is that only 50% of the patient have an optimal response to this type of drugs. Also, you have to know that there are some relevant side effects, and I'm quite positive that you're aware about the flash edema, aware about the headache that these drugs usually cause. And so many patients start to take PDA5 inhibitors, but then the compliance for long-term therapy of this type of pharmacological intervention is poor. And it's even more poor when we start to move to something more important, and I'm referring to intracavernous injection of prostaglandins, due to the fact that the natural history of these patients are usually those that start with low dose PDA5, which can be Viagra or Cialis, so sildenafil, tadalafil, moving to more potent drugs in terms of effect or prolonged effect, or move to more increased dosage. So they usually start with 20 milligrams of Viagra, then they go up to 50, then 100, they do not respond anymore, they move to 20 milligrams of Cialis, they try the intracavernous injection, and of course, many patients would tell you, for me, it's impossible, I surrender because I cannot manage anymore this situation. Of course, when you approach the patient affected by erectile dysfunction, as a cardiologist, I started, 5 years asking a very simple question. Are you sexually active? Do you have any sexual concerns or problem that you would like to discuss with me? And with this simple question, usually patient, starts to be confident, or sometimes if the wife comes with them, they usually push them to open their heart and telling you what's going on in terms of sexual relation. Of course, you need to be very cautious, very gentle, and also explain why you are asking this type of questions, due to the fact that they need to know that ED can be the first symptoms related to a heart problem. And this is the reason you, as a cardiologist, are asking if they have any sexual concerns that they want to discuss. Usually, there are many reasons given by patients and the clinicians why we are not taking a sexual clinical history. Patients, they usually have the feeling that there is a lack of opportunity. We are here to discuss about the dual antiplatelet therapy after I've done stenting. We don't have time, to discuss about other problems. There is always a very important sense of embarrassment and shame. You have to always keep in mind that there is a societal taboo against an open discussion of sexuality. And as I told you at the beginning, they really not feel very optimistic about the outcome of this type of discussion. For us, as a clinicians, there is always time constraints. We don't have time to discuss about this. Of course, we are not very confident, and so we feel that there is a deficit in communication skills. There are some also reimbursement concern, so it's not our problem, our urologist, andrologist problem, especially for female physicians. There are discomforts to ask sexual questions to a patient of opposite gender, or to a patient young, or to an elderly patient. We may feel that we may embarrass them. And of course, as a clinician, we are also not receive a very adequate training in sexual health. But again, with a simple question, as a cardiologist, you may discover first that there is a problem in the erectile dysfunction, and second, that this may also discover a problem for coronary artery disease and other peripheral disease. Of course, if you open your mind and then are willing to ask if they have some erectile problem, of course, you should ask if the patient has difficulty in obtaining an erection, or if the erection is suitable for penetration, so it's strong enough to be able to penetrate the partner, and if the erection can be maintained until the partner has achieved an orgasm. With these three simple questions, you are exploring with the first question, are you difficulties in obtaining an erection, the arterial part, because the patient will say, no, I cannot achieve an erection, and when I achieve the erection is not suitable for penetration. You can be sure that if you submit this type of patient to a penile dynamic Doppler, the urologist colleague will say he has a peak systolic velocity that is reduced. So you have identified only with the anamnestic history the arterial part. Then the other question, are you able to maintain the erection? This will explore the venous part, because they can say you, I have a normal erection, but I cannot maintain this erection. It lasts 1 minute. And you have an idea that there is a venous problem or a mixed problem, due to the fact that the patient can tell you, I have not very potent erection and I cannot maintain it. Probably the flow is impaired, the sponge cannot increase the volume enough to be able to squeeze the vein. So only with the sexual interrogation related to the characteristic of erectile dysfunction, you can obtain very important information for which district has probably a problem. Then, of course, other question are if ejaculation occurs. This, of course, relates more to the prostate problem, or if they are experiencing sexual satisfaction. So if there are some psychological problem, couple problem, and so on. This is what I just told you. If you have a two machines and penetration problem, usually it's an arterial insufficiency. If you have an erection maintaining problem, usually it's a venous insufficiency. And of course, you can have both, so which is called mixed insufficiency. You should ask, this question either in an open way, or you can, provide the patient with a questionnaire. The questionnaire is called IEF, which is International Index of Erectile Function. It's the gold standard for urologists and andrologists, and it's composed, as you will see, of 5 questions. How do you rate your confidence that you could get and keep an erection? When you have the erection with sexual stimulation, how often your erection are are hard enough for penetration? Are you able to maintain the erection? How difficult is to maintain your erection? And when you attempted the sexual intercourse, how often was it satisfactory for you? And you score these 5 questions from 1, which is very low or almost never, to 5. And at the end, you will get the maximum point, it's 30, which is absence of erection. You will have a light ED problem that goes from 17 to 25, moderate from 11 to 16, and severe from 6 to 10. This is very important when you will start your network. So how we should approach this patient. These questionnaires need always to be done due to the fact that it's reproducible. So you will have the basal AIES-5 score, you will do a mechanical revascularization, and you will ask the same question at 1 month, 3 months, 6 months, in order to have a very reproducible and very easy way to see if clinically the patient has improved. So this is very easy to find on the internet and extremely fast to obtain from the patient. What next? Of course, if a patient presents with a score of 8, it means that he has a severe erectile dysfunction. And then, of course, as a cardiologist, you have to submit them to a dynamic Doppler, which, of course, is done by the urologist colleagues or andrologist colleagues, or vice versa. When you will have your network established, the patient will arrive with a dynamic Doppler, because the urologist, the andrologist will know that you are treating with drug-eluting balloon, with stents, this type of patient, and when they found a positive Doppler, they will submit the patient to you. So what is important for us to understand? You have 3 basically situations: an inflow insufficiency, when you have a peak systolic velocity equal or less than 25 centimeters per second. The end diastolic velocity is less than 5, so it's normal, with the normal resistance index, which should be greater than 0.8. The last index is not reported quite often, but you will have it in some Dopplers. So you have to know that urologists usually calculate the resistance index. The second situation, it's a pure venous leakage, when you have a peak systolic velocity, which is normal, greater than 25, you have an increased end diastolic velocity, greater than 5 centimeters per second, and a reduced resistance index, less than 0.8. Of course, you can have the mixed pathology. So peak systolic velocity less than 25, and diastolic velocity greater than 5, with a lower of 0.8 resistance index. These are the 3 scenarios that you will see in a dynamic Doppler. For the whom are not acquainted with the word dynamic, it means that the urologists usually do a basal examination, and then they do inject prostaglandin, which is called Caverject, 10 milligrams usually. They wait 10-15 minutes. They will ask the patient for a stimulation, self-stimulation, and then they repeat the Doppler after upgrading the tumescence and the erection that the patient has obtained. So you will have a scale from 1 to 5, indicating that the tumescence is poor or the tumescence is good. This is what dynamic Doppler means. Okay, so we briefly outline the anatomy. As I told you, you have this situation. For the few of you that probably are not acquainted with the peripheral angiography, basically the first time that you will do a pelvic angiography, you will be completely confused due to the fact that there are many branches that originates from the interniac iliac artery. As I told you at the beginning, it is fundamental to identify the superior gluteal and the inferior gluteal artery, and then everything that goes towards the bladder and the prostate, you will call superior vesicular artery, middle vesicular artery, obturatory artery, and then you will have the pudendal artery that in 80% of the cases will originate independently. So after the inferior gluteal artery, will run around the bladder and then will give you several branches, some perineal artery or also hemorrhoidal artery that will irrorate the sphincter of the anus, which is here. It will give you some bulbal artery, and which is usually runs together with nerves for the sensation at the level of the glandis, and then it will end up into the dorsal artery of the penis and the deep artery of the penis that usually we are not able to visualize because they are extremely small. As I told you, remember, not all men are created equal. So you will have some anatomy, some variables that differ from what I just told you. So you may have a pudendal artery that originates from the inferior gluteal. You may have a pudendal artery that originates from the obturatory arteries. So my suggestion is to submit the patient to an angio-CT at the beginning of your experience. You will have the opportunity to evaluate very well the anatomy, to get oriented which projection will provide you in the angiographic suite with the best projection to identify the pudendal artery. And you will see that after 20 examination, you will be able to identify yourself the pudendal artery. But this is the situation at the angio-CT. You can clearly see how we are able to visualize at angio-CT the arteries of the pelvic district. And again, this is the interniac iliac artery. This is the superior gluteal. You have the anterior division with the inferior gluteal, and this is the internal pudendal artery. I told you that it goes around the bladder, and then it gives you the dorsal or common penile artery and dorsal penile artery, which you are able to visualize. This is a very nice paper that has identified the different zone for treatment. 90% of the time, we are talking about zone 4A, 4B, and 5A. So proximal internal pudendal artery, mid pudendal artery, distal pudendal artery. Rarely you will have a zone 5B with the dorsal penile artery because it's again very, very small, so it's difficult to understand the disease. And again, this is an AP projection. This is a lateral projection, so it's what we do in angiography. We do a 45-degree homolateral projection. And you see that the pudendal artery makes this curve, which is very characteristic. You have the bladder here and the artery that runs around the bladder and then moves in the middle segment to give the common penile artery and the dorsalis penis artery. But of course, if you do in the first cases that you are willing to treat CT angiography, I usually recommend to give nitrate, sublingual nitrate. You can even do intracavernous injection together with your urologist, so prostaglandin injection to increase the vasodilatation and to evaluate better this type of anatomical region. Again, you see that only a minority of the patients show a disease of the common iliac, of the internal iliac, only 5%. You see 30% are on the common penile artery, 30% distal internal, 12% proximal internal. So the majority of the atherosclerotic plaques you will find in the zone 4A, 4B, and 5A of the paper that I've just showed you. So we are talking about 4A, proximal pudendal artery, 4B, mid pudendal artery, and 5A and 5B, so distal part and common penile artery. Another thing that we have developed in my lab is the angiography, the CO2 angiography. And you have on the panel A and panel C the normal contrast media angiography. Panel B and panel C, you will have a CO2 angiography. Now you can clearly see from panel B and panel D that the patient in panel B has a good contrast or contrast gas opacification with CO2 angiography of the cavernous body, while patient in panel D has a very poor opacification by CO2 of the cavernous body. Now, as you will see, both pudendals in panel A and panel C seems to be normal. I don't see any atherosclerotic disease in both situations. And this gives you a little glimpse on the fact that there are some patients with problem not in the arterial or venous district, but in the cavernous body per se. Is what the urologists call increased fibrosis of the cavernous body. This usually occurs when the patient has ED since 5 years, 7 years. He has been treated with PDA5, he responded at the beginning, then he had to increase the dosage, then he does not respond anymore, and then he surrendered. So you see this type of patient 2 years after, they do not respond anymore to PDA5 by mouth or intracavernous injection. The situation usually is this: the fibrosis of the cavernous body is so important that it will be difficult for you to offer anything to those patients. These are the patients that need to be submitted to penile implantation. So in order to, have an artificial erection, but it's very difficult that we can solve their problem with any mechanical intervention. This is a normal angiography that I would like to show you. This is a homolateral 45 caudal projection of the right pudendal artery. And you clearly see that there is a very tight stenosis in the proximal part of the pudendal artery, and there is also disease in the middle part of the pudendal artery. So Dario asked me to do a little break, and I would like to conclude this first part with the following suggestion. We as a cardiologist should always take sexual history during patient examination, due to the fact that the rule is, remember, if you don't ask, they will not say. IF questionnaire and dynamic Doppler evaluation are usually sufficient to make a diagnosis of vasculogenic erectile dysfunction. And then angio-CT is very easy to perform. The radiologist needs to be trained to follow and to recognize the pudendal artery. I can give you some tricks for radiologists to identify exactly the pudendal artery. And of course, angio-CT is sufficient to complete the diagnostic track in order for you to have detailed information regarding the presence of atherosclerotic disease and, of course, healthy status of the cavernous body when you decide to bring the patient into the angiographic suite and perform also a CO2 angiography. So I will interrupt. Dario, should we give you them 5 minutes, 10 minutes?
Well, there are a couple of questions. Would you like that I read to you?
Of course, yes.
Okay. Yes, the first one is from Dr. Roxana Merginian, and say, should an erection be inducted in the patients during the intervention?
This is a very good question. Honestly speaking, there is a German group that usually performs Caverject injection during intervention due to the fact that increasing the flow will make you, or for you, easier to evaluate, especially the distal part. I've done more than 500 now angiography, and I'm not used to do it anymore. But again, especially at the beginning, you have to, put you in the situation that you need to visualize what's going on. So if you want to do it with your urologist colleague, please do it. Call him, and he can do, or she can do, Caverject injection in the cavernous body, which is a very easy thing to do. So you can do it also by yourself. You have to know that the urethra is in the middle part of the penis. So if you bring up the penis, you will have the urethra in the center part and the cavernous body laterally. So of course you have to puncture with an insulin needle, so very small laterally. So don't puncture centrally because the risk is to penetrate and perforate the urethra. But if you puncture laterally, you can do it also by yourself. But I'm encouraging to work in a closed setting with the urologist, who are, in my personal experience, very willing to help, because for them, you know, this is a new world, a new type of approach, and when you solve a problem, they will be very, very happy, due to the fact that, for instance, this is the situation in Italy. I don't know in your centers, but the penile implantation is very expensive, and you know, not many patients, of course, are willing to do it. So they will do angiography. They will be submitted to angiography due to the fact that for them it's a good hope and a good alternative to penile implantation.
Thank you, Max. Then we have another question that is, how often has Dr. Sangiorgi encountered erectile dysfunction in patients with isolated internal genital artery disease?
This is another good question. I have to say that, you know, by experience, let's start about decades of life. 30 to 40, 40 to 50 is extremely rare that the patient will have organic disease, probably less than 2%. Many patients, you know, in this age range have more psychological problems with their partner. So if you start to explore, you know, you will see that our patients usually that have had a depression episode in the past, they have a bad feeling about self-esteem. Now, if you start moving in the same age range of myocardial infarction, which is between 50 and 60, let's say that almost 50% of the patient will have a problem of erectile dysfunction related to atherosclerotic disease of the pudendal artery. If the patient is diabetic, you can bet that he has organic disease. In diabetes, many urologists believe that there is endothelial dysfunction, which is absolutely true, but is the precursor, as we say, as we know, as a cardiologist, of an atherosclerotic disease. You will have also some nerve problem. And these, of course, also is important in order to have a normal erection. But of course, mandatory is that you explore if the patient has atherosclerotic disease. And in your clinical practice, I can, you know, give you several examples of patients who have been submitted to a pudendal angiography due to the fact that they had erectile dysfunction. And in case of diabetes, I always tend to evaluate also the coronary part. And many times you will have a stenosis of the coronary artery that the patient doesn't know to have because he's completely asymptomatic due to the fact that he is diabetic. And of course, we treat first the coronary, and then the patient comes back to do the pudendal artery district. So I would say from the decade of 50, you will move between 30 to 40%. Then the decade 60 to 70, 40 to 55, 60%, and then over 70, usually there is in more than 60% of the cases atherosclerotic disease in some segments of the pudendal and dorsalis penis artery. Now we move on. What is probably the most interested part and the reason why we are here. Okay, this is the PAMPI study results. So the acronym is for pelvic angiography in non-responder to phosphodiesterase inhibitor, and probably partially answers the last question. Now, you will see that, so in patient affected by ED and not responder anymore to phosphodiesterase therapy, you have, disease of the internal pudendal arteries. This is the percentage stenosis. And of course, you have also coronary artery disease. So as I told you, the two situations, they usually run together, and you should be acquainted. Usually the atherosclerotic in the PAMPI study was focal in nature, so it's not usually a diffuse disease. It's not very common to have diffuse disease. They have usual focal stenosis. You also, by experience, I'm telling you this, you have also to be aware that if you try to do a super selective contrast media injection in the pudendal artery, so engage the pudendal artery with the catheter that usually could be either a right Judkins or a left mammary artery catheter that will help you a lot to engage the internic iliac artery from the homolateral approach. You may have some vasospasm. So if you have doubts that what you see is not a true stenosis, you can, as we do in the coronary district, do an injection of nitrates and therefore realize if it's a spasm or if it's a true stenosis. Now, I want only you to focus on the fact that when you will start to discuss with urologists, they are not aware of this type of revascularization. This is a shot from the European guidelines. So as you will see, they moved from the PDA5 inhibitor oral therapy, sildenafil, vardenafil, tadalafil, whatever. They moved to penile injection of prostaglandin. They then go to intraureteral suppository or vacuum constriction device. And after that, they recommend penile prosthesis. In the mid way, some urologists would recommend low intensity shockwave therapy, so ultrasound, to increase vascularization at the level of the penile base and the cavernous body. But mechanical revascularization is not contemplated into the European urology guidelines. Now, I'm just for your information, on the 28th of February, we will have the Italian Andrology Society that will publish the new guidelines where the mechanical revascularization will be considered, and probably in the mid-October, we will have a consensus paper with the Italian Society of Urology where the mechanical revascularization will be considered. So this is just to tell you that you will have to, bring the case with several papers that we will evaluate in the following slides that have started to treat a vasculogenic erectile dysfunction with mechanical revascularization. You have to be aware also that the field, especially at the beginning, was hampered by the Zen trial. The Zen trial was a trial that was performed at Harvard, so Boston Mass General Hospital, where they implanted stents, everolimus drug-eluting stents, in patients affected by vasculogenic erectile dysfunction. And you see that they have had a late loss of 34.4%. So it was not a very good treatment for this type of patients. Then a few years later, 4 years later, so in 2014, the first series from Taiwan was published. The first trial was called Perfect One, where patients were treated by plain old balloon angioplasty. Again, here, binary restenosis, 41%, very high in this type of patient. Then we moved to a Perfect 3 trial, presented at TCT in 2015, where 3 groups of patients were enrolled. Patient treated by drug-eluting balloon, patient treated by drug-eluting stent, or patient treated by plain old balloon angioplasty. Endpoint, CT angiography at 8 months, with a primary endpoint of binary in-segment restenosis, and then secondary endpoint, clinical success, which was defined as a delta of more than 4 points of the International Index of Erectile Function 5 questionnaire. Okay? What happened? The drug-eluting stent arm was prematurely interrupted due to a very high restenosis rate. 64% experienced restenosis. This is actually the binary restenosis. You see 75% experienced binary restenosis. In the plain old balloon angioplasty group, again, 67% experienced binary restenosis. But then if you look at the drug-eluting balloon group, 26% experience binary restenosis. So very good results with a clinical success of 85%, so an increase in more than 4 points. We are talking about patients who do not respond anymore. They have a severe, to PDA5, they have severe ED, and they move at least to an upper class. So from severe to moderate. It means that they start to respond again to phosphodiesterase inhibitor, or they move to a very light class where they will not utilize PDA5 inhibitors anymore, but they will have a natural sexual intercourse. Now, Dario will share you, these are all the study, anecdotal, case reports that have been published. But as you can see, there are several now paper, also our paper first experience in 2018, and now we are in the publication phase of the more than 360 cases that have been treated with the drug-eluting balloon. And of course, now we move to the idealized requirements from DCB. Of course, you must have a good PTCA balloon. You must have, and we will discuss, Limus drug. You must have a good carrier in terms of biocompatible excipient. And of course, all of these engineering characteristics will identify an ideal drug coating balloon. For my experience, I think that sirolimus is the best coating, of course, for stent, we know that, but also for drug-eluting balloon. As a unique pharmacokinetic profile, you know that it's a potent antiproliferative agent, you know that it's a powerful immunosuppressive agent, has an anti-migratory cell effect, so stopped smooth muscle cells from detaching to matrix and moving to the surface of the endothelium, and maintains the cells in G0 phase, or in the resting phase, limiting apoptosis. In terms of pharmacokinesis, rapamycin and analogs, you know that they are cytostatic, while paclitaxel is cytotoxic. The margin of safety is much, much higher for sirolimus compared to paclitaxel. Therapeutic range is wide, while in paclitaxel it's narrow, as both drugs have anti-restenotic effect, but sirolimus has also an anti-inflammatory effect. And this, of course, has an important effect for the endothelial dysfunction and inflammation that diabetic patients have usually present at the level of the intima layer of the wall. These are some slides just to show you that there is a very strong clinical based evidence in coronary artery stenting with the sirolimus, which is now the anti-restenotic drug of choice in square compared to the triangle. So with paclitaxel, you have the superiority in terms, especially in a diabetic patient. These are from the different drug-eluting stent trial, ICER SMART 3, SPIRIT 4, DES Diabetes, SPIRIT 3, the compare, you can clearly see the in terms of efficacy, TLR or TVF, so target vessel failure at 2 years, that the advantages that the sirolimus brings to our patient. You are aware of the problem that I think now has been solved, but however, you have to know that there has been an aware of the FDA regarding the paclitaxel eluting balloon utilization. And now there has been published a very large meta-analysis last week in the New England Journal from Swedish groups that does not indicate that paclitaxel has an increased mortality in peripheral intervention. However, for 1 year, there was a big forum discussion regarding the mortality related to paclitaxel in the peripheral circulation. Of course, sirolimus has some problems due to the fact that sirolimus has difficulties in entering arterial tissue after balloon dilatation. So you need a sort of instant glue or a carrier that is required to transfer the drug from the balloon to the tissue efficiently, due to the fact that sirolimus is a lipophobic drug compared versus paclitaxel, which is a lipophilic drug, and therefore transfer very well the endothelial cell barriers. There is also a problem with extent tissue retention due to the fact of that sirolimus must be sort of continuous delivered over time in order to maintain efficacy therapeutic levels. And of course, you have to protect sirolimus. We have a large experience with the nanolute technology offered by MagicTouch. What is also important to understand that MagicTouch right now is the only drug-eluting balloon with a CE mark indication for treatment of erectile dysfunction. So if you want to be on the safe side, and so do not utilize off-label products, you have to know that MagicTouch has the CE mark for ED. How does the MagicTouch transfer sirolimus into the arterial wall? Well, first of all, the sirolimus is converted in submicron particles, and these microparticles are encapsulated into a phospholipid carrier, and you will have the image here. So these are the phospholipid carrier that encapsulate the microparticles of sirolimus. Then these microparticles with the phospholipid carrier, usually it's again electrostatic upon pH variation. The MagicTouch attaches these microparticles through a spray coating on the balloon surface. And when you inflate the balloons, upon the pH variation that is present in the body, the sub-microparticles of sirolimus diffuse into the deep vessel layers. These are beautiful images, experimental paper demonstrating the absorption of sirolimus. On the upper side, you have sirolimus, which has been labeled with a fluorescence substance, and so you are able to specifically identify where the molecule is inside the arterial wall. You see that at 1 hour, it's present at the intimal layer, past the internal elastic lamina, which is the first barrier. 3 days, again, you will have diffusion of the drug into the media layer, and at 7 days, sirolimus, you are able to find the other drug. I don't want here to discuss, I want just you to know that in the market you will have other sirolimus eluting balloon This actually is our experience with the MagicTouch that has been presented in May at EuroPCR. The registry that we have done, it's called Suation, and we evaluate patients affected by erectile dysfunction, not responding anymore to PDE5 inhibitors for at least 1 year, presenting with an international index of erectile function score less than 12, and a dynamic Doppler with catheter injection showing a peak systolic velocity less than 20 centimeters per second. I think that this is the patient frame that you should evaluate. You know, they should not respond anymore to PDE5. Probably 1 year, it's too much, you know, 6 months, but at least they have to be treated in the past with PDE5. They must have a severe erectile dysfunction and, of course, a positive cover jet Doppler test. Efficacy endpoint of the Suation study, which is sirolimus eluting balloon utilization for treatment of vasculogenic erectile dysfunction registry, have been a composite efficacy endpoint of the delta international index of IEF score at 6 months follow-up greater than 5 points, and an increase in the Doppler peak systolic velocity of 5 centimeters per second point at 6 months follow-up. So if they had 15, they need to move to 20 as a peak systolic velocity. Safety endpoint, freedom from target lesion revascularization at 8 months follow-up. These are the clinical variables in the study group. You clearly see very large presence of diabetic patient, insulin dependent 28%, non-insulin dependent 30%. You know, they all have tried phosphodiesterase inhibitors, some of them intracavernous prostaglandins, some of them boost of testosterones, beta blockers, patient in beta blocker in 30% of the cases. However, these are the lesion procedural characteristics, target lesion in 29. This is what we have presented at PCR now. The registry has moved to almost 62 target lesions. Again, you see 90% of the patient presented a disease in the internal pudendal artery, minority in the common penile and dorsal penile. The majority of patients had left disease or right disease, but there are 26% of the patients who have showed also bilateral disease. We usually treat them at the same time, so we treat both arterial or bilateral disease, especially for a psychological problem, due to the fact that if you treat one side, the patient does not respond very well. He probably lose the, you know, trustness in the procedure. So we tend to offer them a complete revascularization of both pudendal district. Endovascular intervention, you see, as we do usually, we perform pre-dilatation with standard balloon dilatation. In few cases, when you have a flow-limiting stenosis, you have to place a stent, a coronary stent. The range usually goes from 2.25 to 3.0 if we are talking about large proximal pudendal district. but you see that the length of the lesion is usually very, very focal, as you see in this slide. Procedural success, which means stenosis less than 10% in 100% of the cases. So we are always able to dilate this type of lesions. These are the results that we have presented at EuroPCR. You see in blue, improved by 5 points. This refers to IES in 74% of the cases at 3 months, 70% of the cases at 6 months, with an improving Doppler peak systolic velocity, more than 10 in 68% of the cases. So again, I want you to remember that these are patients who do not respond per protocol anymore to PDA5. Means that they have, again, an opportunity to have a normal sexual intercourse with this type of mechanical revascularization. Now, you have to know that, of course, my group in Italy is not the only one performing this type of intervention. There is a very active group also in Switzerland, and these are the reports of their experience, again, utilizing POBA, drug-coating balloon, or drug-eluting stent, 82 cases. This was published in the Euro Journal of Endovascular Therapy. These are the results, which of course you can see are parallels to what we have seen from my experience. They extended a little bit more the follow-up, and you can clearly see they count a minimal clinical improvement, which is considered as 4 points in the IF6 score at 12 months in 65% of the cases, and which is for me very good results in this patient population. Again, they have utilized Viagra study points. These results are splitted for question number 3. So ability to penetrate, to have an erection and penetrate the partner, ability to maintain an erection in order to complete the sexual intercourse. And you can clearly see the percentage of improvement that we are able to offer to this patient population. There has been a problem that the Swiss group has outlined, which is the early recoil after plain old balloon angioplasty. So what they recommend is to perform a dilatation with plain old balloon angioplasty, wait 10 minutes, and re-evaluate the patient. If you see an early recoil, they recommend to place a scaffolding represented by a drug-eluting stent, and do not perform drug-eluting balloon in these cases. This is an example from this study group. You see clearly a tight stenosis of the proximal part of the pudendal. They treated with a very long balloon due to the fact that there was a stenosis here, and then a subocclusion in this part. This is 1 minute after. Then if you wait 10 minutes, this is what they have observed. And due to the early thoracic recoil, they place a drug-eluting stent in this district. These are just some examples that I want you to bring you. This was a non-insulin dependent diabetic, 61 years old. He was treated in 2017 for non-ST elevation MI with 2 drug-eluting stents on LAD and LCX. He was suffering, as I told you, this is the first alarm sign of ED since 2016, and he had a non-ST elevation MI in 2017. Probably if somebody would have asked him, that if he was suffering from a sexual problem, they probably would have evaluated him before the occurrence of non-ST elevation MI. However, what is done is done. The patient was not responding anymore to PDA5 from 8 months. IF score, severe erectile dysfunction, 8. The score less than 10, it's a severe. And so he was submitted to pudendal angiography. This is the situation, chronic total occlusion. As you can clearly see, there is a stump at the origin of the pudendal internal. You can clearly see here the external gluteal artery. This is the internal gluteal artery, and this is at the anterior division. So the pudendal runs here in the middle. And so this is what we have done with a Samurai 0.14 wire. We crossed the lesion. We treated the patient with MagicTouch ED after pre-dilatation, 2/20, and this is the result at the end of the procedure with a delta IF that moved from 8 to 22. So this patient returned to have a normal sexual intercourse without any PDA5. Again, another patient, a younger one, 54 years old. You see the decade, it's always the same. Again, another diabetic patient. He had no cardiovascular event, coronary angio CT performed, which was completely negative, erectile dysfunction since 2018, not responding anymore to PDA5 from 1 year. He did chronic chalice, so tadalafil administration every morning, 5 milligrams plus Spedra on demand, 6 application of low intensity shockwave with no beneficial effect, IF score of 6, and then again pudendal angiography, and this is the angiography. You can clearly identify the pudendal artery here. Again, this is the bladder. The vessel, as you see, runs around the bladder. You can clearly see a very diffuse, in this case, disease of the mid and distal part of the pudendal artery and dorsalis penis artery. So what we have done, again, these are some other projection. We felt that the obstruction in the middle part after pre-dilatation was too severe, so we implanted a Cruz drug-eluting stent, 2.5/18 implantation. We did also optimization of the drug-eluting stent with non-compliant balloon inflation, but you can clearly see before and after, again, tight stenosis at the level of the pudendal artery, which was optimized by drug-eluting balloon pre-dilatation and drug-eluting balloon. You can clearly see how the flow improved after MagicTouch ED at the level of the dorsalis penis after an inflation of 2 minutes. These are other case examples, coronary arteries from a patient which look normal. Again, you can clearly see in this angiography pudendal stenosis in the proximal part, here in the middle part, mid-distal part. You see here the dorsalis penis that goes towards the penis basal, and you can see some cavernosal artery here, probably very, very faint, but in this case we were able to see. So again, very diffuse disease that we treated, again, with drug-eluting stent, and in this case, with paclitaxel-eluting balloon for this diffuse disease of all the pudendal artery, with very nice result in a delta IF of 18. You have to be aware that when you will start to treat complex cases, so you will feel very confident. This is again another anterior division. You see the superior gluteal and inferior gluteal artery. So this is the origin of the pudendal artery. We did a perforation in order to reopen this artery. However, it's relatively safe in terms of complication. If I mean, for perforation, we usually do nothing. We inflate a balloon at the level of the gluteal arteries, and for 5, 10, 20 minutes, due to the fact that there is no risk of ischemia in this region, and therefore you solve the complication. You may encounter some fistula creation due to the fact that the venous part runs parallel to the arterial bed, and again, this usually occurs when you utilize an oversized balloon. So my recommendation is to start to do pre-dilatation with a smaller balloon, and then move to a 1-to-1 maximum balloon to artery ratio when you will utilize the drug-eluting balloon. These are examples that I already showed you. What is quite interesting that we will start this randomized clinical trials thanks to Concept Medical, where we will do a sham procedure. Due to the fact that many urologists, when you will talk to them, they will start to criticize and saying, well, but there is a very big psychological effect. So what we will do, we will randomize patients with the same enrollment criteria in 2 groups. One will be the delayed interventional group, where we will do a pudendal angiography and do a sham procedure. The patient then will follow the same treatment that we give after a normal procedure, so PTA with sirolimus-eluting balloon and or drug-eluting stent. And then we will have a crossover study at 3 months if the patient does not respond. And of course, I'm expecting that they will not respond due to the fact that they are not responding here. So due to the sham procedure, we will do the crossover and perform the PTA also in the sham group after 3 months. So this is what we're going to bring to the guidelines. The first-line treatment, which is proven, are the lifestyle changes and the utilization of pharmacological treatment, so the PDA5. The second line treatment, which is for the urologist, low intensity shockwave treatment, we would like to add a PTA treatment at this point. Then, of course, there are also other treatments which are still experimental, are not approved. We need a very large study, PRP, staminal cell, and especially mononucleated cells. So there are colleagues that perform autologous cell ultrafiltration, and then they inject those cells, especially monocyte and lymphocyte, so not polynucleated, but mononucleated peripheral cell into the cavernous body. This is the type of the treatment that we perform every day in case of limb salvage. It has been demonstrated by different studies and now meta-analysis that the wound at the level of the peripheral limbs are able to be wounded with this type of treatment, and there are some urologists also performing this type of treatment. The challenging in this situation is that beside MagicTouch, we don't have any dedicated device. So MagicTouch is the only one with the CE mark. We don't have any dedicated stent, and this, of course, may represent a challenge that we have to overcome in the future. The other challenge is for sure the complex anatomy, but when you will start to approach this patient, my recommendation is the first 20 patients, please submit it to angio CT. Of course, you have to create a network with the urologist. If you start to ask by your own, due to the fact that these are patients that we see every day as cardiologists in our outpatient setting, you will start to ask, they probably will start to talk. And therefore, you can become also for the urologist colleague referrals for them in order to evaluate this patient, to start PDA5 inhibitors, and to follow them and bring them to the revascularization, mechanical revascularization. Of course, PTA is technically demanding due to the fact that you have to know the anatomy very well, but as I show you, good results can be obtained with the mechanical revascularization, not only in terms of angiographic results, but especially with the clinical results in the relatively long-term follow-up, at least 1 year. And of course, we are starting now randomized clinical trials to prove that the mechanical revascularization of this district can be adopted and recognized as a second-line therapy in case of vasculogenic erectile dysfunction. And I thank you very much. We are in time for your attention for this webinar. If there are any questions, Dario, if you can
yes,
please.
Thank you so much. Thank you so much, Max. For sure, has given a big panorama to the actual situation and about your experience. This is very useful in most of cases because people, even if the theory is a lot, the practical aspects are too important to be avoided during discussion. So thanks also for sharing your experience that day by day is going to increase. So this will give for sure.
I would like to say the one last thing, actually two last things. First, in February, a new book, which is called the Vasculogenic ED from Bench to Bedside, will be published. and I really hope that Dario can provide to all the colleagues a copy of it in order to have the complete scenario of this type of patient, how they should be treated, the angiography, the pitfalls and challenging in the angiography, CO2 angiography, and treatment. Second, we will see when we will be able to reopen a normal meeting. However, we are planning to organize an ED Academy Congress with urologists, radiologists, andrologists to discuss about these aspects. And Dario will be the ambassador if this, I hope, will occur after this pandemic will be over, if the vaccine will be effective, and have you in Milan for this academy symposium.
Perfect. So you added some gift at the end of the things, because the book, as per my knowledge and after my experience with this period together, has given a very important aspect regarding the whole aspect to consider. Many experience inside the book, many key opinion leaders there that have contributed to give the proper explanation of different parts, urologist, andrologist, and so on. So we'll give a really good thing as additional value, because it's the first time that something like this is performed. So we are going to for sure give some of these books if we will take this for once will be published.
But it will be important, you know, Dario, due to the fact that, for instance, for angio CT, the radiologist could see what type of protocol colleagues that have started before are utilizing to show the kind of images that we have shown here. You know, the tricks that you can utilize in order to have a perfect visualization, and not only in angio CT, but also during angiography. So there are several aspects that this book will touch. Professor Holmes, who is the chief of cardiology at the Mayo Clinic and Foundation, it's co-editor. He has written a couple of chapters, and of course we are honored that such a prestigious institution is on board. And as you said, many KOL have participated.
Yeah, it is very good. Yeah. Okay, thank you, Max. There are a couple of questions before leaving. The first question arrives, from Dr. Mamun Alomari, and say, do patients with vasculogenic impotence have loss of libido?
You know, this is it's a good question. Now, if you look at the IEF questionnaire, indeed, the complete questionnaire are 15 questions, and the last two, they usually encompass also the libido. Now, you have to understand that we are entering into the brain
of the patients.
Yeah, due to the fact that you know, we have a proverb in Italy that states, if the fox cannot reach the grapes, it says that the grapes is not good.
It's bitter. Yeah,
exactly, it's bitter. Which means, you know, many men with a loss of self-esteem that have tried PDF-5 for, 2 years, they lose interest in. There are some men that they say, no, I really would like, so mentally I get excited, but at the end, I'm so frustrated that I cannot do anything, and this is the situation. So you will encounter both in your clinical practice. Patient also that have a very good score at the IF questionnaire. The two question, so you will have a score of 10 at the IF questionnaire. And men who tells you, oh, I really lose interest. I understand that nothing can be done, and so that's it. Period.
Thank you, Max. Then we have a question from Kyrgyzstan, from Dr. Zeynep Bopoiva. What long-term data are available for percutaneous treatment of vasculogenic erectile dysfunction, and how do you often do patients come back for a reoperation? I think that you discussed it during your presentation. If you want again, give a couple of small pills for summarize.
Yeah, in this large series that I'm publishing, which will encompass 380 cases, we do have the 3 years long-term follow-up data. We have closed the follow-up and the statistical analysis a couple of months ago. I can tell you that the clinical success is maintained approximately around 50% in these cases that have been treated at 3 years follow-up, which was completed in 87% of the cases out of 380. How do often this patient comes back? We usually perform normally 1 month follow-up with the IF score, 3-month follow-up with the IF score, 6 months follow-up with IF and Doppler, and 12 months follow-up with IF and Doppler. Now, of course, with the paclitaxel eluting balloon, we have, let's say, positive Doppler, which means that the patient at 6 months, the Doppler showed an increase, at 12 months showed a new decrease, and these are the patient also clinically, because the patient says, oh, before I was not taking any more chronic chalice, only on demand. I was very, very happy. Now I started again that I need every day the chalice, and on demand doesn't work so well anymore. So usually we resubmit them to the Doppler, and in 23% of the cases you have to redilate the artery. This is by heart, but I hope that you will see the final paper after 3 months. It's in submission right during these days, so I hope that in 3-4 months we will get the final acceptance. What I forgot to mention, but I think it's another important point, is that in case of mixed, and we are also collected this data, in case of mixed insufficiency, which is arterial and venous, most of the time when you treat the arterial part, the venous part will disappear. So the true venous deficiency or insufficiency is extremely rare, less than 3–4%. Second, in these cases, surgically, there is no indication due to the fact that it's like the varicose vein. The venous plexus tend to reform collaterals. By CT scan, you can evaluate if you can embolize the venous plexus due to the fact that the plexus basically it's either a Y, so there is the dorsal venous of the penis and two branches that runs out the dorsal venous of the penis, and this of course can be embolized. It's called the prostatic plexus. We have another variable which is crural plexus. There are many collaterals originating from the dorsal veins, which is impossible to embolize. But again, the embolization procedures, it's extremely difficult, needs to be done by echo guidance at the base of the penis without local anesthesia because the vein contracts, and so it's impossible if you do anesthesia to punch the vein with the needle. In my experience, 50% of success in puncturing the vein. After 2–3 years, we utilize a mixture of lipiodol and embolizing particles. Of course, the embolization need to be done like during varicocele treatment under Valsalva maneuver, but 2.5 years, there is a recurrence. It's like surgery. So I, honestly speaking, do not recommend this type of procedure anymore for pure venous leakage. For mixed venous leakage, you will see that treating the arterial part will solve the vein part. So for the pure vein, we utilize constriction ring at the basal of the penis, which of course are not very well tolerated by the patient, but it's a mechanical intervention that can help the patient.
Yeah. Then we have another question that you can answer very fast. That is, in average, how many DCB are used in a procedure like this?
Diffuse disease is not so common. I show you a couple of cases, but it's not so common. We utilize one normal semi-compliant balloon, and we wait now 10 minutes for the elastic recoil. If the elastic recoil does not occur, we utilize a 1:1 MagicTouch ED, and then gone. So it's usually focal. With 20 millimeter, you will cover 80% of the cases. Then there are some cases where you have to utilize 30 millimeter coronary normal semi-compliant balloon, and then go with MagicTouch ED 30 millimeter length, because there is diffuse disease. If it's over 2 drug coating balloon, but this is the maximum.
Okay.
If we have to place the stent, Dario, just let me tell you, we do spot stenting. We do not do, I don't want to say full metal jacket, but we usually treat semi-compliant, drug coating. If we need the stent, spot stenting, like in the case I showed you during the webinar.
Yeah, there is also a question that I think that is related connected to this one, that is, if a dissection or occlusion of pudendal artery happen, will this lead to ED? But this is for sure.
Okay, you have to consider that these are patients with ED. So you will not bring to the table a patient not having ED. I want to be clear. We are, I don't want to say interfering, which is a bad word, but we have, let's do the positive word. We have to work together, the urologist. So they will send you the patient to you, or you will propose the patient to them. I will not treat anybody who has a good response to PDA5. It's like coronary artery disease. You know, the first line therapy, it's pharmacological. You know, if you have a chronic stable angina responding to you know, beta blocker and nitrates, and the patient is asymptomatic with let's say negative stress test, I don't think that we should bring the patient on the table. It's exactly the same. If the Doppler is normal and the patient responds to PDA5, it's not a good candidate. So you will do angiography which looks completely normal. Then the physiological part, so the cavernous body fibrosis part, it's another story. But you know, you have to perform the Doppler, you have to perform angio-CT showing that there are no major stenosis. Then you could propose to the urologist colleague the CO2 angiography evaluation to see if there is opacification of the cavernous body. Does the treatment changes? No. This is a patient that will probably need to be submitted to penile prosthesis implantation if they suffer by ED, not responding to PDA5, and not showing any type of atherosclerotic disease along the pudendal artery course.
Okay. Then we have, if you can please go back to the slide where is declared the inflation time and pressure. If you can go back to the presentation.
Of the equation?
Dr. Zainab Bofoeva, can you please say?
Was not. Inflation time and pressure.
Yes.
What is it?
And pressure, that is, I think that maybe is related also to the device where there are mechanical properties.
I'm trying to see drug-eluting stent, drug-coated balloon, no
Maybe
access.
inflation where there are some
These are situation criteria. These are clinical variables. Medication before the procedure, medication with an impact on EF. Then target lesion, arteries affected, artery treated, diameter stenosis, MLD, peak systolic velocity and diastolic
maybe
velocity.
Max can be the technical page regarding MagicTouch ED.
Let me go back. This is the other. I don't remember this inflation.
I don't know,
but the
but
question, what is the question?
no, the question is, please show the previous slide. Okay, then we said, what is the previous slide? Inflation time and pressure.
No, I don't. Inflation, maybe one cases.
During one case, yes, I guess is this.
This is MagicTouch 220 for 3 minutes. Yeah, we as the usual utilization of drug-eluting balloon, I especially in the peripheral district tend to do prolonged inflation. We are not in the left main where we cannot keep the balloon inflated more than 30 or 45 seconds. Here you can keep the balloon inflated for 3 minutes. This is what usually we do in peripheral intervention when we treat superficial femoral arteries with drug-eluting balloons. And therefore, we do the same in the pudendal district. We do prolonged inflation.
Perfect. And then we have another question that is cavernous insufficiency, cause of erectile dysfunction, can be treated with the repair of venous system.
I mean, the question is not clear to me. Let's try to understand. If a fibrosis of the cavernous body is suspected, it means that the patient has severe endothelial dysfunction, the patient has increased collagen content into the cavernous body, so collagen 3, which replace the normal content, increase extracellular matrix. This is, of course, biopsy study, autoptic or histopathologic evaluations. The venous part has nothing to do with this fibrotic content. The venous part it's either related to a primary venous leakage or is related to the fact that the cavernous body does not increases its volume and does not squeeze the vein. So in both cases, as I told you, most of the time the patient should be submitted to penile prosthesis implantation due to the fact that the microcirculation is gone and there is really nothing that we can do.
Perfect. And then we have both arterial and venous system should be addressed to treat the ED.
Yes, as I told you again.
Okay.
When you treat
it's the same doctor. So.
Yeah.
And finally, is there soft copy of presentation to share?
Oh, of course. I will send it to you, Dario.
Thanks.
And they will have it.
Okay. Then we have. Do you treat bilateral disease at the same session or treat one side? Yes. Okay.
No. Psychologically, it's very important. You introduce a variable.
Okay.
I mean, I want to say this, and then I have to go. When you treat this type of patients, you have to realize that there are some patients that when we call them at 1 month and we ask them, how are you doing? They would say, I haven't tried yet. And of course, you say, but why you haven't tried? I have fear that the procedure has not worked, and therefore I haven't tried yet. So it's important that you treat everything that needs to be treated, because it will be devastating for them, saying, oh, has not worked, the procedure has not worked, and you haven't treated one side. So maybe if you would have treated both sides with a complete revascularization, they would have had a clinical improvement, which of course psychologically for them is extremely important.
Perfect. And finally, do you perform procedure by radial access?
You may, if you have long enough catheter sheet. You know, the only problem that I will see is that when you have a variable in the origin of the pudendal artery, you have to manipulate the guiding catheter in order to engage or utilize microcatheter, angulated microcatheter to engage the pudendal artery. Sometimes it's extremely difficult from the femoral. From the radial, but let's say that in a straightforward case, you should be able to treat them from the radial. Yes.
Perfect. Okay, I think that's it. There is on the chat box the link to perform the final questionnaire we are going then to publish officially. I kindly ask to you to fill in this because it's very important for us also to understand how the things have gone. And Professor Sangiorgi will be very happy to receive your feedback about this type of things. And by Concept Medical, I want to thank Professor Sangiorgi, first of all, and all of you to attend the webinar. We hope that every one of you have enjoyed and have learned a lot from this, and we hope to stay tuned and have a next session maybe in few months.